Hi, and welcome to today's presentation on acute respiratory distress syndrome. Today, we are going to manage this condition. And if this is the first time you are watching this, I will encourage you to go back to our previous tutorial where we looked at the causes, the pathophysiology, the presentation, as well as the diagnosis of acute respiratory distress syndrome. Now, there are no established treatments for acute respiratory distress syndrome, but treating the underlying condition, for example, eradicating infection with antibiotics or even surgery, and also providing support for each system is very, very important in the management of this patient. And so system wise, we are going to provide respiratory support, and what we do over here is ensuring frequent chest x-rays to help us detect pneumothorax as well as fluid overload and pneumonia, which may all complicate acute respiratory distress syndrome. Now, pneumothorax in particular should be sought if there is a sudden increase in ventilation pressure or a deterioration in the blood gases, and we can use the bedside ultrasound to help us in detecting this pneumothorax, as well as CT scan may also help us in detecting any occult pneumothorax. Frequent physiotherapy is also important because it will help us to prevent plugging of the airways by sputum. Now, if there is suspicion of plugging, for example, by a lobar collapse or even a deterioration in the blood gases, then bronchoscopy and lavage can be, used to help this patient. Now, we also need to manage the sepsis, and as we know, sepsis may have even precipitated the lung injury, or it may have developed during the course of the ARDS. However, the systemic inflammatory response syndrome is often associated with acute respiratory distress syndrome in the absence of infection, and so detecting sepsis may be a bit difficult. So what we do is, if we find any changes in sputum color, or if there are any new shadows of infiltrations on the chest x-ray, then it may point to pulmonary infection. Now, also other sources of sepsis should be frequently reviewed, such as looking at the line sites. Also, the line site here, I mean the intravascular, intravenous IV cannulation sites. Also, the urine and the wounds on the patient should all be looked at to trace any source of infection. Now, if infection is suspected, then appropriate samples should be sent for microscopy and culture. We can get, samples even from the lungs through bronchoscopy and lavage. Now, antibiotic therapy should be started immediately based on the results of the investigations that we've done. We may also start empirical antibiotic therapy since sepsis, which is caused by, or sepsis which causes severe cardiovascular instability or even impairment in gaseous exchange, may deteriorate this patient condition, and so we can start blind treatment of antibiotics on this patient till the results are in. Now, we also need to support the renal system, and renal failure is very common in acute respiratory distress syndrome. This may be due to the underlying condition, or even a low cardiac output, sepsis, and so on. There are a lot of things which can, complicate, acute respiratory distress syndrome, thereby causing renal failure. And so, renal replacement therapy, such as hemofiltration, may also help to improve gas exchange by removing excess fluid from this patient. Now, the nutritional status of this patient should be reviewed and managed accordingly, and so enteral nutrition should be established quickly And we can do this by using the nasogastric feeding tubes. Alongside, we must give some prokinetics such as metoclopramide, or we can also feed the patient through nasojejunal feeding. And if this is not helping, then we may need to resort to a total parenteral nutrition for this patient. Now, we also need to support the cardiovascular system of this patient. And with the cardiovascular system, our main aim is to maintain adequate oxygen delivery to the tissues. In acute respiratory distress syndrome, the cardiac output can be decreased due to sepsis or to as a result of medical treatment such as providing high ventilation pressures, also positive end expiratory pressure, and or even the inverse inspiratory and expiratory ratios, which are all ways of ventilating the patient. And so monitoring of cardiac output and filling pressures are very, very important in acute respiratory distress syndrome. Now, how do we even know that this patient is having inadequate cardiac output? Sometimes even simple things such as the presence of cold fingers may imply that the patient is not receiving enough blood supply. Now, another important thing that we must, note over here is the fluid management of this patient. Fluid management is always difficult in this case, since excess fluid will worsen the lung function, and also inadequate fluid will exacerbate renal failure. So we are always, in this state of fix. You should be careful in order not to over infuse the patient, and also be careful in order not to be under infuse this patient. Now, if cardiac output monitoring devices are not available, we can use the systolic pressure variation to help us to determine whether we are over transfusing or infusing this patient with fluid, or under infusing, and also to determine when the patient needs fluid. For example, when we are using the systolic pressure variation, what we do is we measure the systolic blood pressure when the airway pressure is held at 30 centimeters of water, and also we measure when the airway pressure is held at 10 centimeters of water. And if the difference that we get is greater than 10 millimeters per mercury, then it indicates that fluid may help this patient, or this patient may need some fluid. Now, we must also make sure that we provide warmth of this patient, and also, like I've said, judicious use of our fluids. Now, the appropriate targets that we set for ourselves with our cardiac output is a cardiac output of 3.5 to 5 liters per minute. We must make sure to have our HB between 7 and 9 grams per deciliter, and we must make sure that we do not over transfuse these patients, and we must also ensure that we maintain an oxygen saturation of more than 90%. So this is the target that we must set for ourselves when we are managing these patients. So these are some supportive measures that we can provide for these patients. Now, the second step in the management of patients with acute respiratory distress syndrome is ventilation. This is very, very important part of the management. Now, the aim of ventilation is to improve oxygenation without causing further damage to this patient, or causing further damage to the lungs. Now, difficulties may arise here. This is because some alveoli are normal and open, whilst others, are not, opened. They are rather, stiff and collapsed, and so there is a bit of a challenge over here. And so it is therefore necessary to try to open the collapsed alveoli without damaging the normal areas of the lung, or the normal areas of the alveoli. It is also important to note that the main causes of ventilator-induced lung damage are high fraction of inspired oxygen. And that is when we give more or a high dose of fraction of inspired oxygen. What we do is we increase the availability of free radicals, which may damage, the tissues, and also cause over distension of the alveoli. And so we must be very, very careful when we are, administering oxygen or supplemental oxygen to these patients. So what do we do? It is important that we initiate as soon as possible ventilatory support. And so the continuous positive airway pressure, or the CPAP, may benefit most patients, who are having acute respiratory distress syndrome, especially in mild cases. And so in such cases, we may give a non-invasive oxygen, such as through the face masks, and also the nasal cannulas. And when we are giving oxygen through these medium, we are delivering oxygen, or a fraction of inspired oxygen, at a rate of 70%. Now, most patients will require early intubation and also mechanical ventilation. And the indication for early intubation and mechanical ventilation may include when we find that the patient is hypoxemic, or the patient is experiencing increased carbon dioxide, which result in respiratory failure, when the patient is also having acidosis, as well as when we find the patient exhausted and also in a reduced conscious state. We must intubate this patient and provide ventilatory support to this patient. And when we intubate this patient, we are giving or we are able to give a fraction of inspired oxygen of about 100% to these patients. Now, before we can do this, we know such patients are always agitated, and so sedation of these patients are very, very important. So we must provide profound or adequate sedation of these patients before we can even start with our ventilatory processes. This is because when the patients begin to struggle or cough, it can cause loss of the recruited lungs that we've gotten already, and this may worsen the oxygenation levels of the patient. And so in order to prevent worsening of oxygenation, we must prevent the patient from struggling or even from from coughing. Now, if the sedation alone is not able to relax the patient, then we may go ahead and provide some, muscle relaxation of this patient, so that we can adequately ventilate our patients. Now, the benefit of ventilation in this patient is that it will reduce the work of breathing and also reduce the oxygen demand of the tissues. And once the oxygen demand of the tissues are reduced, it will lead to the correction of acidosis, as well as improvement in the cardiovascular status of the patient. So in ventilating the patient, we also provide the positive and expiratory pressure to this patient, and this is often very, very, very necessary during the treatment phase. And this type of ventilation that's giving a higher levels of carbon dioxide can be tolerated. That is when we are able to give increasing PEEP at such a standard level, then the patient will be able to tolerate such levels of high carbon dioxide. And this is what we refer to as the permissive hypercapnia. Now, the target that we set for ourselves is to administer a tidal volume, or set a tidal volume of 6 to 8 mL per kilogram body weight. And why we do this is to minimize alveolar distension and also volume trauma to these patients. Also, our fraction of inspired oxygen must be less than 50%. and this will help us to avoid oxygen toxicity in these patients. Then the PEEP and the fraction of inspired oxygen should be adjusted to recruit collapsed alveoli and also guarantee sufficient oxygen saturation. And so the PEEP, the normal PEEP that we may require here is to be between 10 and 15 centimeters of water, and we should avoid trying to get higher levels of PEEP at this particular time. Now, we also need to ensure that our oxygen saturation is more than 90%, or our partial pressure of arterial oxygen is more than 55 millimeters per mercury. An important thing for us to note over here is that a high respiratory rate and a low tidal volume are the principles of lung protective ventilation, and so we shouldn't increase the tidal volume without ensuring that the patient is receiving or the patient is breathing more. So we always need a higher respiratory rate to help us protect the lungs, and also to help us improve ventilation. When we do all these, then we are going to increase the functional residual capacity of the patient, and our main goal of recruiting the alveoli will be achieved. Now, like I said before, the higher levels of PEEP, should be, should be avoided. We shouldn't give higher levels of PEEP. This is because when we give higher levels of PEEP, or positive end expiratory pressure, it decreases the venous returns and this will also decrease the cardiac output. And so PEEP should be set to maximize oxygen delivery rather than setting PEEP to deliver oxygenation alone. So it's very, very important to maintain our PEEP between the 10 and 15 centimeters of water. Now, when all these have failed to help us achieve, the targets that we want, then we must employ other methods such as the pressure controlled inverse ratio ventilation. Now, the key features of this procedure is that the inspiratory time is prolonged till it is equal to or greater than the expiratory time. For example, we can use an inspiration and expiratory ratio of 1:1, or 2:1, or 3:1. What we are trying to do here is we are trying to allow time for the poorly compliant lung areas to be well ventilated. And once those poorly ventilated areas are now well ventilated, it is going to improve oxygenation. So we increase the what? We increase the inspiratory time and try to reduce the expiratory time so that the air can stay inside the lungs for quite some time to try to open the collapsed alveoli. Now, it will also help us. This procedure will also help us to prevent over distension of the less diseased alveoli, or with the aim of improving oxygenation. Another thing that we can do is to nurse the patient in the prone position. Now, this method, or this procedure has a massive improvement, in oxygenation of these patients, and so we try to nurse these patients in the prone positions for about 12 to 24 hours. And the kind of improvement that we sustain, or the kind of improvement that we get, can even be sustained when the patients are turned to the supine position. Now, the mechanism which is involved over here is we are going to get a better matching of the lung perfusion with ventilation, and also we are going to get redistribution of the dependent lung edema. This said, it is also important for us to, note that these patients are always critically ill. And so there is always a practical challenge when we are trying to turn the critically ill patient from one position to the other. And so we must be very, very careful when we are, trying to do this, procedure that's trying to ventilate the patient in the prone position. Now, the third part of the management of acute respiratory distress syndrome are what I have, or what is referred to as the additional measures. These are measures which may help to improve the outcome, or the prognosis of this condition. And so we have things like the nebulization of the patient with prostacyclin. As we know, prostacyclin is a prostaglandin which has a potent vasodilator effect. And so when we nebulize these patients with prostacyclin, it produces pulmonary vasodilation, thereby dilating those vessels in the well ventilated parts of the lung, and by so doing improving ventilation and perfusion, matching in those areas. Now someone may say, once we are causing such potent vasodilation, it may cause hypotension. Such effect is not observed. This is because prostacyclin is removed from circulation at a very faster rate, and so the side effect of hypotension may not be a problem at all. And so this prostacyclin should be continuously nebulized at a rate of 5 to 20 nanograms per kilograms. We can also give inhalation of nitric oxide, and it works almost in the same way like the prostacyclin. It's a selective pulmonary vasodilator, and it is used in doses of about 1 to 40 parts per million. I didn't write that over here, but we give the nitric oxide in 1 to 40 parts. We can also give corticosteroids. In some literature or in some areas, they withhold corticosteroids. However, corticosteroids may be, administered, and so we can give methylprednisolone to help suppress ongoing inflammation process during the fibroproliferative phase of acute respiratory distress syndrome. Now, the initial regimen of methylprednisolone is 2 milligram per kilogram daily. And after 3 to 5 days, we must see, some improvement in the patient. In the next 1 to 2 weeks of giving the methylprednisolone, we have to try to taper the dosage of methylprednisolone from 0.5 to 1 milligram daily. Now, when we are not getting any results from these corticosteroids in this period, we must discontinue the use of corticosteroids once. Now we can also give what we call surfactant therapy, and as we said earlier on, we know that surfactant helps in increasing the surface tension of the lung, and also helps in the expansion of the lungs. And since they are denatured by the plasma proteins, we may give some surfactant to replace the lost ones, and so we give this one with the hope of improving the compliance and the alveolar stability of the lungs. It's also going to help us to decrease the fluid which is found in the lungs. Now, the last thing that we can also do is what we call the extracorporeal membrane oxygenation. And what happens here is there is a pump oxygenator which performs gaseous exchange, and by so doing, the lungs are allowed to rest, so they do not take part in any process. So it is this pump which is used in oxygenation, though it is a very important procedure to be done. It's only available in some specialized centers, and so we may not have it in almost all parts of managing centers. So basically, these are the three main management steps that I have for you in acute respiratory distress syndrome. Thank you very much for your attention.